Welcome to part 3 in our 5-part Cancer Genetics CME series titled Genetic Testing Outcomes and the Importance of Cascade Screening. In this recorded presentation, we will review current guidelines for screening and treatment for patients with hereditary cancer risk and provide resources to identify guidelines in the future as they are updated with new evidence. Attendees will be prepared to recognize cancer predisposition syndromes and where to locate information regarding medical management. The importance of cascade screening for hereditary cancer will be described, and we will review limitations of genetic risk assessment and the importance of family and health history to guide cancer screening recommendations. I'm pleased to introduce the speakers for this session. Kari Thorson is a board-certified genetic counselor practicing at the Fred Hutch Cancer Center. Dr. Brian Schertz is a board-certified physician and assistant director of the University of Washington Medicine, Genetics, and Solid Tumor and Informatics Lab. And Bree Pagan is a board-certified genetic counselor practicing at the Swedish Hereditary Cancer Clinic. Our learning objectives for this session are as follows: to differentiate between types of cancer genetic testing results, to recognize possible medical management changes for positive cancer genetic testing results, to identify published risk models and when to use these for breast cancer screening, and to interpret VUS results and explain their implications, and to define the importance of cascade cancer genetic testing. CME is available for watching this recording. If you are watching this in a group setting, please make sure to register for the webinar and complete the evaluation as an individual to receive CME credit. This activity has been planned and implemented in accordance with the accreditation requirements and policies of the Accreditation Council for Continuing Medical Education through the joint providership of the Federation of State Medical Boards, the Washington State Department of Health, and the Washington Medical Commission. The Federation of State Medical Boards designates this enduring activity for a maximum of 1 AMA PRA Category 1 credit. Physicians should claim only the credit commensurate with the extent of their participation in the activity. This webinar is not funded by any commercial entity. All faculty members are asked to disclose all financial relationships they have had within the past 24 months with any ineligible companies, regardless of their potential relevance of each relationship to the education and the amount. Of today's speakers, Brian Schertz, MD, PhD, discloses that he is president and board member for Connect My Variant, and also a consultant for the Constantinium Biosciences. All relevant financial relationships have been mitigated. None of the other speakers today or planners for this activity have relevant financial relationships to disclose with ineligible companies. Today, we will not be discussing any off-label use or any investigational use of medications in this presentation. And with that, I will turn it over to our first speaker, Kari Thorson. Thank you.
All right, thank you so much, Bree. So today we'll just be broadly reviewing the spectrums of results that can come from cancer genetic testing. And this spectrum can include pathogenic or positive disease-causing variants, variants of uncertain significance, and benign variants. So first off, we'll start with positive results. Oh, and there's a spectrum there, just kind of showing the different types. So when a patient receives a positive, it's my role as a genetic counselor to review with them the cancers and those risks associated with whatever gene they're positive in. And the screening guidelines that have been established by the National Comprehensive Cancer Network, or NCCN, they have established guidelines that we'll review with the patients and also discuss the cascade testing of biological relatives. And majority of the cancer patients that or the majority of patients that I see have active diagnoses of cancers. So staying in touch with the primary care providers and other oncologists is important to let them know about the results, as some of these cancer results, testing results, can impact treatments or surgical decisions. And here at Fred Hutch, where I work, we have a lot of syndrome-specific clinics that can help with patients' management of all their different cancer screenings and kind of get them connected with that. And next one. we'll kind of go into how all these positive results impact a patient. So our first example here is hereditary breast and ovarian cancer syndrome, sometimes called King syndrome. And this kind of more well-known one, it's primarily involving the BRCA1 and BRCA2 genes. There are sometimes more moderate risk breast cancer genes that can be grouped into this, but for the most part, this is the primary one that we think about, primary genes. And like most hereditary cancer syndromes, it is an autosomal dominant condition. And we won't go into detail in terms of all the different guidelines, but kind of highlight what the guidelines are for different individuals. So for BRCA positive patients who are assigned female at birth, the high risk breast cancer screenings include like alternative breast MRIs, breast mammograms starting in the 20s, working into the 30s, and going every 6 months or so with some type of imaging. And that type of imaging regimen, it would be put in place for someone who's not opting for a risk-reducing surgery or prophylactic mastectomy. And so another point in terms of breast health for patients who are BRCA positive and assigned male at birth, the guidelines can be a little bit different. And we know that the difference between BRCA2 compared to BRCA1, that there are stronger considerations and recommendations for male breast and prostate screenings, as we see a higher lifetime risk for those genes. And then we'll keep going into seeing the more gynecological related risk factors and recommendations. So one more tidbit about the BRCA genes, the BRCA1 gene is highly associated with increased risk for gynecological cancers and slightly lower risk for BRCA2. So while there is risk-reducing surgery recommended for prophylactic ovarian and fallopian tube removal for both genes, the age at which those are recommended to do so can be a little bit later for BRCA2 patients. I think also it's important to note that there's a lot of text here in the last year or so. There's been a bit more nuanced and a wide variety of recommendations from NCCN regarding surgical or non-surgical cancer screenings for more like gynecological organs. And so some of those patient decisions around surgeries or just screening measurements can be based off of the particular gene, the family history, or their own reproductive values and goals. And this slide here just highlights the difference between the prostate cancer screenings for those assigned male at birth, whether they have a BRCA2 variant, where that's more highly recommended for screening versus for BRCA1, just consideration of prostate screening. And I think with kind of highlighted above there for one type of cancer risk, pancreatic cancer in BRCA patients, that type of screening recommendation is more based off of family history. So if there's a positive mutation as well as a family history of pancreatic cancer, they're likely to have that recommendation as opposed to not if there's no family history. So this will kind of highlight what this actually means for a patient. So here we see a proband who is assigned female at birth, age 33, and they have a significant family history of ovarian and some breast cancer, primarily ovarian. And we see that there's a positive BRCA1 variant in the proband themselves and on the maternal side, of course. Their mother had a prophylactic mastectomies, as well as having their TAHBSO or hysterectomy and bilateral saphenous oophorectomy. But the patient themselves, the proband, had not had any of those surgeries before. So their screening would include what we had previously just discussed, those increased breast screenings, discussing of any surgical decisions depending on their reproductive decisions. But as we can see, they have sons, and so whenever the sons do testing, if they were to be positive, and as well as the male relatives on their maternal side, they would be more so consideration of prostate cancer screening and at least some type of clinical breast exam when they get in their 30s. All right, and Another condition that we commonly see in the clinic is called Lynch syndrome, and this is a leading hereditary condition for colon cancer. And Lynch syndrome is also dominant, caused by 5 different genes, and every gene kind of has different associations or different risk factors or risk percentages, depending on the type of cancers. And we do primarily see colon cancer and endometrial cancer risks for Lynch syndrome, though, as you can see, there's a lot of other abdominal organs, some other non-abdominal organ cancer risk as well, like ovarian, small bowel. And as I said, that every gene has their different lifetime percentage risks, and kind of has various screenings depending, but here we list the MLH1 as that does have the highest colorectal cancer risk, going as high as 61%. And as you can imagine, there's a lot of different screening recommendations attached to Lynch syndrome. And so here's just a list of what MLH1 guidelines are. A lot of these screenings start in the 20s and 30s, sometimes a little bit later, depending on the organ of interest. There's usually an annual or biannual colonoscopy recommended for Lynch patients, no matter what the gene is affected. But the age at which those start might vary, might not be as early as 20, might be in their 30s. And so I think it's important to kind of walk away knowing that modifications in Lynch syndrome guidelines and screenings can be made, obviously based off of the gene, but also on the family history and other personal risk factors. And we'll see here on the next slide that we have a case example for a family that has MLH1 positive, and the proban here is assigned female at birth who's 53. They have a personal history of a colorectal cancer at 28. So quite young, and later on they had a small bowel cancer at 52, and they were seen to be positive for an MLH1. This is presumably from the mother's side, as we see maternal history of a lot of colorectal cancers. And so, although this has only been tested in the patient, we would recommend that the maternal uncle who's surviving to do testing, as well as maternal half siblings, just to confirm that it's on that side. But in terms of the screening for this patient, they do still have their ovaries, but had a hysterectomy. So their provider, or if they see a Lynch syndrome specific provider, they might talk about a prophylactic BSO kind of at any time in their life now. And for their children, they have 5 sons, 4 daughters. And as we had reviewed before, that if any of them are positive, we recommend colonoscopies likely at least by 20, given their mother's very young onset. Their daughters can discuss hysterectomies and BSOs, usually 30s, or whatever their reproductive goals are. And so, yeah, I mean, that would be modified person to person. Our last syndrome example is called hereditary paraganglioma pheochromocytoma syndrome. And this one is just to highlight, a different type of condition that is less common that we see, but still a little bit different. And this condition is dominant and can be caused by a handful of genes. Some of the cancers that are included, of course, are paragangliomas, which are nerve cell tumors, and the pheochromocytomas are related to the adrenal gland. Some other cancer risk we'd see are renal cell carcinoma and gastrointestinal stromal tumors. And then because of these primary tumors being related to excess hormone production, some of the symptoms might not be as typical for other types of cancers, like just general pain. We might be looking more for anxiety, hypertension, excessive sweating. So it's just something a little bit different to look out for sometimes, and like the HPI. And understandably, the screening for someone with this condition would be regular biochemical measurements or blood pressure monitoring. And of course, MRIs, just kind of do a whole body scan of any of those paragangliomas or pheos. And very similar, kind of sound like a broken record, that these screening guidelines can really be modified based off of the gene that's present in the individual or mutated in the individual. So as you can see, the SDHD genes can sometimes be a bit more aggressive, younger onset compared to other SDH genes, so it starts a little bit younger. And then also for this condition compared to what we others saw, that this can be childhood onset. So the discussion around a patient and their children might, and their follow-up testing might look different as well. Right, so that was kind of the positive results and the implications for screening, and now we'll go into the negative results. And this is just an example of what a typical test report might look like when someone is negative or only holds benign variants in the cancer genes. And there's a lot of interpretations for negative results. The most common interpretation of a negative, especially in a person who's affected with cancer, is that their cancer is truly sporadic or random. It doesn't have a genetic or inherited etiology to it. We know that inherited cancer syndromes make up roughly 5 to 10% of cancer cases, so just statistically, more likely something's going to be random. But other less common reasons to why someone might be negative is due to technical limitations and the inability for the test itself to catch all pathogenic variants in one gene, or that the gene of interest related to the family history, that gene was just not tested. And that can be depending on the provider that ordered it or what kind of panel you're looking at. And we also do need to consider who we're testing in the family. Is the person you're testing the best and most informative person for the family as a whole? So if you are testing an unaffected patient who is turns out to be negative, that's reassuring for them and their cancer risk, but it might not be guaranteeing the absence of a hereditary condition in the family. And we'd, of course, also be looking at lifestyle factors and other risk models to help provide more information to a negative person. And then here we are just highlighting the different types of features we're looking at when we're doing a family risk assessment. We're taking their family history and some more high risk or suspicious features, of course, cancers that are very young in diagnosis, so 50 years or younger. If there's clear dominant inheritance, any rare cancers, or in their molecular tumor profile, is there something that's more rare going on? And so those are some patterns we keep an eye out for. And kind of on the other spectrum, some reassuring features are somewhat the opposite. Cancers at older ages, really common cancers, or something that's just not a very clear pattern. And I think that one high risk feature that sometimes can go overlooked is that if an individual's ancestor had a risk reducing surgery that kind of skews the presence of a possibly positive gene family. So just trying to do an organ inventory for people and their ancestors can be helpful. We'll kind of talk about the utility of risk models here, and risk models are primarily used by myself and my colleagues to help unaffected negative patients, but who do have a significant family history of cancer. And then they can provide lifetime risk of any type of, certain cancers, and these risk models can be syndrome specific. Risk models too can be attached to NCCN guidelines. So usually a certain percentage threshold can then result in NCCN guidelines to follow. Here, some of the common risk models that we use. The Tyrer-Cuzick is the main risk model that we tend to use to estimate a lifetime risk or a 10-year risk for breast cancer in unaffected patients. And the Gale model can also be used for similar, but more so if you're looking for a risk of breast cancer within a specific time frame. We find that the Gale model tends to underestimate family factors or family history, but still a good option for some people. Lastly, we have a PREM5 model, and this will estimate the probability of someone holding a germline mutation for Lynch syndrome. It's not always commonly used, but can be helpful if you have a more nuanced results or complex family history. So we can go on and see some case examples. So here we have a 43-year-old assigned female at birth patient. And so she has a family history of breast cancer in her mother, who was 55 at the time. The mother had passed BRCA testing 7 years ago, but was negative. Then the maternal aunts had breast cancer at 52 and 48. And the patient tested themselves negative for germline mutations. But when we consider this family history and input the patient's health characteristics like weight, height, or other lifestyle, we get the Tyrer-Cuzick score. And the Tyrer-Cuzick score here is 34%. And so for a person who's assigned female at birth, this is for general population, we'd see a lifetime risk of breast cancer around 13%. And this would, for this patient who has a 34% lifetime risk, that is considered elevated. And the NCCN does recommend high-risk breast screening for anyone who has over 20% lifetime risk. So the NCCN recommendations for high-risk breast screening would to be start breast screening 10 years younger than the youngest diagnosis in the family. So her aunt was 48, so this patient should start at 38. They're in their 40s, so they should start now. And they would be doing alternate breast mammograms and MRIs every 6 months. Another pinpoint that we would talk about with this patient is for the mother to do updated genetic testing, as they had done BRCA testing more than 5 years ago. This next case here is for colon cancer. This is a proband who's also 43 and assigned female at birth. Their mother had colon cancer at 55, but their uncle had colon cancer at 40. So even without a specific risk model being run or finding a certain percentage, the NCCN does recommend that an individual start colonoscopies 10 years prior to the youngest diagnosis, like the breast cancer. So this person or other family members should start at 30. This person should be starting by now and starting their colonoscopies. This is in comparison to starting colonoscopies at 45 for the general population. And the recommendation, because they have a first-degree relative who's affected with colon cancer, they should be getting colonoscopies every 5 years instead of every 10. And if the mother wasn't affected and it was only the uncle, that frequency might be modified, but for this person, we'd say every 5 years. And then finally here, we'll go review the variants of uncertain significance and what that means for people. So first, to start off, we'll just identify what a VUS or variant of uncertain significance is. And these are variants that are in known established cancer genes, but the data on it is insufficient or conflicting regarding the variant's ability to cause disease or actually impact someone's health. The classification of a VUS, or pathogenic or benign variants for that matter too, are highly dependent on population databases like ClinVar, NOMAD, any case reports or big meta-analysis studies in literature, as well as in silico or algorithmic predictions. And that's a very broad view of like what goes into variant interpretation, as I'm not a laboratory genetic counselor, I don't have as intense training on that, but I think that's just to show that there's a lot of different features that go into what makes a VUS. And we do know that over time, VUSs are often reclassified when more information is discovered, more research is done. And we find that over 90% of uncertains are later changed to be benign or downgraded, or they just might remain uncertain. But that can be reassuring for patients in that because there's a high percentage of downgrades, we do tend to treat uncertains within the cancer realm as negative, and then we can always change that as more data proves us different and proves us otherwise, and we recontact patients at that time if guidelines are established. And I think also something that's kind of more nuanced about uncertains is sometimes they can be eligible for family testing. Sometimes there's so much nuance in the gene, or it's particularly suspicious in that gene for the family history, that sometimes they recommend that an uncertain is looked for in other family members, in particular to that family. So this is our first case regarding variant reclassification. This is an upgrade for a patient who is 63, assigned female at birth, and she had breast cancer at 56. And they did testing and initially found an uncertain VHL, which is associated with von Hippel-Lindau disease. This particular disease can be childhood, usually childhood onset, has a wide variety of a lot of benign and malignant tumors, don't have a strong association with breast cancer. So the family history, her own history, doesn't really match up to this uncertain. Um, but later on, this uncertain result was later reclassified as likely pathogenic, but it was not reclassified pathogenic for VHL, but for a recessive condition called familial erythrocytosis type 2. And so now when we recall this patient and do a follow-up discussion, we're really talking about her carrier status for this recessive condition and talking about reproductive risk for the patient's descendants. And it should be noted that we told the patient that this VUS remains uncertain or remains a VUS for VHL, which is that dominant cancer condition. And this is an example of a downgrade patient for VUS. This is a 54-year-old assigned female at birth who had a diagnosis of leukemia, family history of breast, prostate, and brain. And they received 2 VUSs, one in NF1 and one in POL. And both of those VUSs don't fully explain their own diagnosis or the family history. And they later found that the NF1 VUS is reclassified as benign. And before, there was no action necessary to take when it was VUS classification, and that does remain true when it's now benign. I think it highlights the importance that to still notify the family and let them know of this reclassification if you can, just to provide them a peace of mind moving forward and something they can let the family know that it's not this thing looming over their heads. So that's one example of how that can be more reassuring for a downgrade for patients. And I'll thanks for listening, and I'll pass it on to Dr. Schertz.
Thank you, Carrie. That was excellent. So as you can see, there's things that from the last few last part of the presentation. If somebody identifies they have hereditary cancer risk before they get cancer, then there's all sorts of opportunities for prevention. And cascade screening is what it means is if somebody, well, I'll describe this, is that what happens is somebody gets a genetic test result after their genetic counselor talks to them and they get that result, then they hopefully can talk to their family members. And those relatives getting tested is where the real opportunity is for cancer prevention. 90% of the time that person getting diagnosed already has cancer. And so they're already in the high screening, they're already geared up for high screening. But when the relatives get tested before they get cancer, then that's where the real benefit happens. So cascade screening is called cascade screening because theoretically, this individual who gets diagnosed is going to tell their first-degree relatives. That individual is going to tell their first-degree relatives. That individual is going to tell their first-degree relatives. So it can cascade from one person to another person to another person, and eventually everyone should know about the hereditary cancer risk in the family. We can move to the next slide. This shows a little bit more about kind of what a first-degree relative is. So let's see, this person in the middle has it's affected with a genetic condition like hereditary cancer syndrome. Their siblings are their first-degree relatives. Their children are their first-degree relatives. Their parents are their first-degree relatives. This niece and nephew is a second-degree relative. Now, that initial person who in genetics we call the proband, that initial person can, of course, tell their nieces and nephews, but oftentimes they're going to tell their sibling, and that sibling's going to tell their children. That's how their nieces and nephews are going to find out. In reality, what we see is that cascade testing is a group effort, and multiple people talk to each other. You can go to the next slide. Here you can see kind of a pattern for follow the first for information sharing, and I'm just going to walk you through this a little bit. So let's say someone tests positive. This is up in the top left corner. That person tests positive for a hereditary cancerous variant. So follow their firsts. Some of their first-degree relatives are their children. Each of their children has a 50% chance of having that exact same variant, and they should be tested. Next, follow their siblings. Each of their siblings has a 50% chance of getting having a pathogenic variant, and they can get tested. Sometimes for hereditary cancer, I'm going to go back to the children. Sometimes for hereditary cancer risk, minor children, so children under 18, should wait to get testing if they're not at risk themselves. But adult children should certainly get tested. Okay, back to the siblings. The siblings are getting tested. In this illustration, you can see that by chance, 50% of them are going to get, so it's a coin toss for each individual children. Some families have 5 or 6 people who tend to test positive. Some people have lots of siblings who most of them test negative. But for those that test positive, that sibling now should talk to their children, the nieces and nephews of the person who first got tested. And each of those children has a 50% chance of having a pathogenic variant. Now, for the sibling that tests negative, you can see with the blue writing, then no further testing is needed on that side of the family. If that person tests negative, the genetic variant doesn't skip a generation. And so that person, now those children of that individual may have risk on the other side of their family, but they don't need to be tested for that specific variant because of their relationship with that person. So now, going on to other first-degree relatives or parents. So those parents test positive. Usually one parent will test positive and one parent will test negative. And if you know which of the parents test positive, you know which side of the family to go on. So that individual tests positive. I'm in the top right now. And you can see that the initial person's aunts and uncles then should get tested by chance. But every one of them, there's going to have 50, each of them is going to have 50% chance of testing positive. The side of the family is that where the variant is not traveling, the cascade testing doesn't have to continue on that side. If somebody tests positive, then their children are going to have a 50% chance. So I've walked through this, kind of follow the first idea of cascade testing. We can move on to the next slide. Now, this sounds easy, but in reality, it's not. There's lots of barriers to cascade screening. One of the biggest ones we're actually addressing right now as you're listening to this continuing medical education. Healthcare providers knowing about how to do cascade testing is one of the most important things. Healthcare providers are oftentimes better than patients in having their relatives get tested. On the other side, literature shows that relatives usually would rather hear from their patient, rather hear from their siblings than from hearing from the healthcare provider out of the blue. And so what really needs to happen for optimal cascade testing is for the healthcare providers to be working with the patients and to be letting the patients know that they're there as resources, that the relatives can contact the healthcare providers when the patients talk to them, and to have an ongoing relationship with patients. Now, there's some barriers to that happening. Our healthcare system really isn't geared towards that type of collaboration between primary care providers and or any providers and their patients in terms of family outreach. Insurance doesn't cover that time for providers. The cost of testing can be barriers for patients, but usually insurance covers the testing in those individuals. There's not very many healthcare providers that know about this cascade screening process, and there can also be geographic barriers. You may be comfortable taking care of your patients and their relatives who are in your catchment area, but you might not be comfortable talking to a relative halfway across the country. Some things that have been shown to really help a lot are family letters that the probands can give to their relatives. And that's something that we'll talk about a little bit more in the future, but most genetic counselors are trained to provide family letters that talk to the relatives about what the mutations are, and what the pathogenic variants are, and how what information those relatives need to give to their family members. So they can just give a letter to the family members that has all the detailed information after they tell their relatives about the variant that's traveling in the family. There is with the advent or with the advances in telemedicine, then genetic counselors are available anywhere across the country. And we have genetic counselors here in Washington State that can help patients that are relatives that may be in different parts of the country. And one of the other barriers to cascade screening is actually the barrier of death. Let's say, if we were thinking about that previous slide, if the person wants to talk to their relatives, but let's say one of their parents died at a young age of, let's say, breast or ovarian cancer, then that makes it difficult. That person who died can't get tested. It makes it difficult to know if they tested positive. So you'd have to skip a generation to be able to think about the relatives. And if you can go on to the next slide, actually, you can see that theoretically, and this is a paper by, this is from a paper by Ken Offit and Melissa Frey, I believe from Memorial Sloan Kettering. And they showed that if an individual, if this cascade testing can happen and individuals talk to their first, second, and third degree relatives, then theoretically, we could identify everyone in the United States that had hereditary cancer risk within 10 years if everyone reached out to their first and second cousins. Now, that's something that we need a little bit of help to do. It's something that requires a cultural change to what we've had, and it also requires getting past this barrier of death. So I'm going to talk about some of the things some of the data that's been shown about and what cascade testing looks like over time. And so this is the 30-year experience of a group in the UK about what cascade testing looks like for BRCA1 and BRCA2 patients. And you can see that there are, you can see that for BRCA1 and BRCA2, then you look at the number of positive index patients, then most of the time there's just 0, 1, or 2 additional people that get tested for every index case. Then there's most of the time, 40% of the time there's 0 in female. And there's 40% of the time there's 0 additional female relatives, and 73% there's 0 additional male relatives. In the case of BRCA1, BRCA2, and then much of the time there's 1 or 2 female relatives or 1 or 2 male relatives total. And so we have most of the time, between 0 and 2 or 3 additional relatives to be getting tested. Occasionally, family outreach will happen to 3, 4, 5, 6, and even less commonly over 10 additional relatives get testing after the index individual gets tested. So it's possible for families to really go out broad and to get almost all of their relatives tested. And I'm going to talk for the rest of the talk. I'll talk about some things, some resources available to help your patients really get out to all of their relatives. One of them is the Washington State Department of Health is working with the Genetic Support Foundation for this Cascade Screening Connector project. And so if you have your patients get in touch with this Cascade Screening Connector, then the Genetic Council of the Genetic Support Foundation can help reach out to the relatives and really actually do the outreach to the relatives. That's available in English, Spanish, and Chinese. And so that's something that's a really unique resource in the state of Washington for people to have direct assistance reaching out to family members. So the genetic counselor can actually do the outreach to family members. The other thing is I'm going to talk about is Connect My Variant. Connect My Variant is a new resource. It's a nonprofit organization that was started at the University of Washington. They found that if 2 people have the exact same variant, so same pathogenic variant in, let's say, BRCA1, or same pathogenic variant in MSH2 for Lynch syndrome, then there's a 90% chance that those individuals, if these two individuals share the same variant, it's a 90% chance they inherited that from a common ancestor. And what they found in Connect My Variant, which the initial Connect My Variant research found, was that if 2 people have the exact same variant, and if they're introduced to each other, then that increases family outreach activities by 2.5-fold. And some of the reasons for that is because all of a sudden individuals don't feel as alone, and it becomes a community project with people working to each other. And some of the reasons are because if someone thinks, oh, I have this distant cousin, then they go beyond reaching out to their first-degree relatives and start thinking about reaching out to their second and third-degree relatives to talk about potential genetic testing. So if you move on to the next slide, I'm going to talk about a few things that Connect My Variant does, and then I'll show you how people can sign up for Connect My Variant. So Connect My Variant, again, there's these resources that are made free through this nonprofit to every patient who has hereditary cancer risk. First, they get assigned a family outreach navigator. So these are volunteers that are volunteered to help. They've been trained in family outreach, and have been trained to help people think about the next steps for their family outreach pathway. If they've already talked to their first-degree relatives, maybe they can start reaching out to their second-degree relatives. Or if they've only talked to their kids, maybe they can start talking to their siblings. So they can think outside of the box and think about the next steps. And so this family, when somebody signs up for Connect My Variant, it's totally voluntary, and they can be can have some assistance. So if you want your patients sign up for a Connect My Variant, then you don't have to walk them through that. You can have somebody else walk them through the family outreach process. There's also education. People can get a newsletter which can remind them about family outreach, and they can go to these workshops or see some of the videos that talk about kind of how someone does it, how you work as a team. It also talks about family history, and there were a lot of questions about ancestry, DNA, and 23andMe and GEDmatch, and how you use all of that if you want to use that for family outreach. And so those resources or ideas are available. Once there are large groups with the same family, then Connect My Variant hosts these variant-specific family reunions, and they also have support from the BYU Center for Family History and Genealogy and other professional genealogists to help people find that. And that can be particularly useful if somebody's adopted and they want to tell their biological relatives about their hereditary cancer risk. Then that professional genealogy help can help people to be able to reach out to family members that they don't know about. Connect My Variant also works with patient advocacy groups that are specific for different types of hereditary cancer risk, so that people can get to know other people, not just with their same variant, but with variants in their same gene, and have that support about knowing what to do next. So if you go to the next slide, here's the Connect My Variant website. And if you go to connectmyvariant.org, your patients can just go to this, click that sign up button. And the sign up process is about 5 minutes long. Once somebody signs up, they'll get an email with resources about their specific gene and their variant. And they'll also within a day or two, set up a meeting to help them connect with their family outreach navigator and to answer any questions they have about family outreach. So this is a new resource that's really wonderful and available to others. And I'm going to hand it over to Bree now to talk more about the types of things that you can see with Cascade screening.
Okay, thank you so much, Dr. Schertz. And I got to say, anyone who works in genetics just feels so passionate about Cascade screening because, as both presenters have pointed out already, it has such potential to identify people who would benefit from early intervention. So I'm going to share a couple of case examples, just to illustrate some of the power of Cascade screening in these families. And the first is a family that had presented with a very striking pattern of breast, ovarian, and prostate cancer, metastatic prostate cancer. Next slide, you can see in the earlier generations, there was just a family that was riddled. Very young age breast cancers in the 30s and 40s, ovarian cancer. And so this was very much a part of this family's story. A lot of women in the family would consider it not if, but when they would be diagnosed with cancer. And certainly I met with the family when it was the mom and two daughters who were presenting to me to talk about this. Next slide. And the mom had already undergone bilateral mastectomy and had her ovaries removed, partly because of her own diagnosis of breast cancer at 34, but also this very striking family history. And she had very little interest in doing genetic testing at that point. Again, so much of the family story had been, this is destiny. But her daughters weren't interested. And so we ended up doing testing for mom and identified a BRCA1 mutation. Next slide. So as Kari had presented before, BRCA1 is associated with hereditary breast and ovarian cancer syndrome, which puts females at very high risk for breast cancer as well as ovarian cancer. And because of those high risks, and particularly because they can be young age, we start screening as early as 25, or consideration of risk-reducing mastectomy. And then, of course, we do recommend risk-reducing BSO between 35 and 40. So identifying this in mom was an intimidating thing for the family, certainly, but it was also an answer to something they knew was going on all along. And it did give the girls the ability to test. And if negative, essentially lets them off the hook, which in prior generations, no one could be let off the hook, right? You know, it just felt like a destiny. Whereas anyone who tested positive now has those tools. They know what to do. And I always say it's not the answer you necessarily want in a family, but it is an answer for what's going on. And not just her daughters, the rest of the family benefits from this. So being able to get this out to the mother's brothers and sister allows them to do testing and know if their progeny are also at risk. Males do have some risks associated with BRCA as well. So this was important for the whole family to identify. And even though it was a tough thing, a tough realization, ended up proving very, very helpful for the family as a whole. So I was really happy with the outcome for that family. Here's another example of cascade testing and kind of the importance of how we communicate effectively. So this was a woman who presented with a newly diagnosed ovarian cancer at 59 years old. And of course, we offer germline genetic testing to anyone diagnosed with ovarian cancer because as many as 15, maybe up to 20% can be associated with a hereditary germline mutation. In that discussion, there wasn't a whole lot of significant family history aside from a cousin who reportedly also had a genetic mutation related to colon cancer. You can, next slide. Oh, maybe one more. Yeah. So there's that cousin. And we didn't have a copy of the report at the time. This was a long time ago. This cousin was tested, like 2015. So the patient said, well, I'll go get that letter and that report and I'll hand it to you. But in the meantime, we knew that she was going to benefit from genetic testing regardless. So we got her testing started. And a few weeks later, we got her results. And they were a BRIP1 mutation. So BRIP1 is considered a gene mostly associated with ovarian cancer with a possible increase in breast cancer risk, though that evidence is not sufficient for high-risk screening at this time. But the ovarian cancer risk is high enough to justify risk-reducing surgery, usually between the ages of 45 and 50. And so, you're always kicking yourself when you find these things after someone is diagnosed with an ovarian cancer, but honestly, there wasn't a whole lot of ovarian cancer in the family to begin with. Shortly after getting this report, we did get a letter and a copy of the report from the cousin. We got the following letter, and this was from a very well-intentioned provider who essentially says, and you can kind of click through these, Katie, basically saying that his test results came back showing he does indeed carry a cancer syndrome. This gene increases the risks of developing multiple forms of cancer. The goals is to use this information for genetic consultations to help the rest of the family do proper genetic counseling and testing and surveillance. So all the motivations are there. They're trying to get the word out to the family, very detailed on why this patient had testing, trying to encourage family members to do it. But there are some things lacking, like what is the gene and specifically what does it go along with? And what should people do when they have this gene? So quite honestly, the woman's interpretation of this was, well, this has to do with colon cancer. I had a normal colonoscopy recently. This doesn't involve me. Unfortunately, when we got a copy of the report, it was the same BRIP1 mutation that she had. So clearly this was paternally inherited. And certainly these can hide when you don't have as many females on a given side of the family. So I wanted to show an example of some of the dear relative letters that we write. Dr. Schertz spoke to this. A lot of genetic counselors will write dear relative letters to help facilitate some of this cascade screening. And I would say there are some important elements that make communication like this effective. So the first is just being very clear in your own letter, what is the gene? That helps when they're passing this off to, when a family member gets a letter like this and they're talking to their own care provider, they know exactly what information to transmit. So you can also, next slide, what is the gene? So what's the gene? And then what's the risk specifically? Unfortunately, in that previous letter, there was nothing about ovarian cancer at all. It just said at risk for multiple forms of cancer. And that's also helpful in one's letter to kind of show who is at risk. Just saying it's in a family member doesn't make it clear who else could benefit from this kind of testing. The last thing that the patient pointed out would have been really helpful to know is what would have the intervention have been. So she said specifically, if I had known that I should have had my ovaries removed preventatively, I would have done this test. But that unfortunately wasn't made clear in the letter that she had received. The next thing that can be helpful is just giving resources. So how do patients get in contact with a genetics provider in their area? How do they get this testing done? So usually these are the kinds of letters we send to patients. A lot of genetic counselors, though, will meet with a patient once. It's rare the genetic counselor meets with a patient on a recurring basis. And I think that's where primary care and other providers can have such their patients, because they have those recurring touch points and can remind patients about the importance of spreading this information to their families. A lot of times when patients first find out they have a gene mutation, a lot of it appropriately so, is focused on what does this mean for them? What kind of screening should they be doing? What are their risks? And they're not yet ready to think about what does this mean for my family? So being able to come back to that on a recurring basis can be really helpful. So I got a list of tips of how to communicate these things. And this is a lot of things that genetic counselors do, reviewing with the patient specifically who in the family would benefit. So even beyond just saying, your first degree relatives, looking at the pedigrees together and say, okay, it looks like your brother, your sister, your niece, your nephew, these are people that can maybe benefit from testing and I think gets patients thinking about how do I communicate with those people. And then review what are the kind of the key information that should be communicated with family members. So kind of what is the bullet points they should be sharing with their family. And family members need coaching on this. This can be very complicated stuff. What I found really helpful is identifying who is the family historian or the family connector. So who's the person in the family that's really good at getting information out. There's usually one in the family, and figuring out who that person is can be a great way to get results out to other relatives. As I mentioned, providing those kind of written letters or other materials. As Dr. Schertz pointed out, those other resources like connected variants or even the NSGC, the National Society of Genetic Counselors. There's a way to look up a genetic counselor in your area by zip code. And like I said, reminding patients at subsequent visits. I think we kind of forget to talk about this, and this could be so meaningful for families, and it's a great opportunity and follow-up to keep talking about it.
I want to thank our speakers for presenting and sharing their knowledge with us during this session, Genetic Testing Outcomes and the Importance of Cascade Screening. Speaker bios, as well as links for the other sessions in this 5-part series, can be found on the Washington Medical Commission website. You will also find a link to the webinar evaluation on the Washington Medical Commission website. As a reminder, completion of this evaluation is required to receive CME credit. Thank you very much for viewing this session. Please visit the website to view additional sessions in the series. Thank you.